Welcome back to Beyond Sound. You're listening to episode 2 of our brand new podcast series exploring the fast-changing world of hearing restoration. Whether you're a clinician, a researcher, or a healthcare professional, this is your front row seat to the conversations shaping the future of auditory care. If you haven't caught episode 1 yet, let us take a moment to introduce the Hearing Group, the organization behind this wonderful podcast. The Hearing Group is a worldwide network of leading centers dedicated to advancing hearing restoration. Spanning 5 continents, we share one powerful mission: to collaborate, inspire innovation, and transform outcomes for people with hearing loss worldwide. So, what can you expect when you tune in to Beyond Sound? Well, it's a place where we share the best knowledge from the world's leading experts in cochlear implantation. Each episode brings you expert insights, the latest clinical evidence, and breakthrough perspectives on cochlear implants and advanced hearing technologies. And because learning works best when you can see as well as hear, we also offer a video version with the slides. Here, just a quick reminder, if you're driving, please stick to the audio because your safety always comes first. Anyways, now let's dive into episode 2. Today we're joined by the brilliant Professor Dr. Abdulrahman Hagr from Saudi Arabia, who will guide us through the fascinating topic of bilateral cochlear implantation in adults. Professor Hagr will begin with an overview of progress in cochlear implantation and then take a deep dive into the key questions and concerns surrounding bilateral simultaneous cochlear implantation. Following his talk, we'll open the floor for a panel discussion featuring distinguished colleagues, Professor Joachim Müller from Germany and Professor Ranjit Rajeswaran from India. This all will be moderated by our esteemed hearing member, Professor Javier Gavilan. And yeah, now it's time. Settle in, press play, and let's go beyond sound together.
And we are in Saudi Arabia. Actually, our speaker is not in Saudi Arabia, he's in Istanbul, but he's from Saudi Arabia to meet Professor Abdulrahman Hagr. He's from Riyadh. Professor Hagr is the president of the Saudi ENT Society, as well as of the Arab Academy of Otology and Cochlear Implants. He is a professor at King Saud University and the director of King Abdullah Ear Specialist Center. Professor Hagr is a member and advisor of multiple international societies. He's a real well-known surgeon and ENT expert in cochlear implant all over the world, and is a member of the hearing, and we are honored to have Professor Hagr as one of the active members, most active members of our group. Professor Hagr is going to deal with bilateral CI in adults. Rahman?
Thanks a lot, Jaber, for this wonderful introductions, and good time for everyone everywhere. And I'm really thankful for giving me this chance to present our experience with bilateral simultaneous cochlear implant in adult. And I hope by this presentation we'll be able to answer a lot of concern and a lot of questions that we passed through it a few years ago, and I think we find a good answer for it. So if we look to the history with Professor Muller's, and he explained it nicely, cochlear implant passed through a lot of levels, and it's actually started with adult unilateral cochlear implants. And then with the great success, it moved to the children unilateral, and then bilateral sequential children's, and then bilateral simultaneous. And then few centers nowadays is doing bilateral adult sequential. And I think the ultimate goal that everybody will be interested in it to go to square one with adult and do bilateral simultaneous cochlear implants. But if we think about these issues, there is a lot of concern in those cases, as Professor Morar mentioned also, is first adult, we worried about their balance, and then hearing. What about their hearing until they get fitted with the sound processor? Are they going to be deaf for 1 month until they get fitted for both sides, or shall we wait and implant one side, keep the other side with hearing aid until they are happy with cochlear implant, then we implant the other side? And also concerning the stable map, how long it's going to take them to go for the stable map? The other issues is general anesthesia in adult, and I'm sure every now and then we hear about those side effects of general anesthesia in elderly and the recovery for them and so on, and also how much it could affect their cognitive functions. And with this, we give an extra care for elderly in particular, and children who's younger than 3 years old. This is how it's been shown in the American FDA, the warning for anyone who's younger than 3 years old, and for surgery who's been more than 3 hours. And we know with bilaterals, hardly it takes less than 3 hours for general anesthesia. And what about hearing preservation for those cases? Shall we wait and make sure that we have a good hearing preservation in one side, and then we could do the other side? So these are the top important concern for us when we are doing a bilateral cochlear implant simultaneous in adult. So we look to our experience, and we publish actually a paper in Laryngoscope about bilateral cochlear implant in temporal bone fractures. And we know in those cases, they lost their inner ear function, the hearing and the balance. And in spite of this, they did not show any major balance problems. And even in spite of doing bilateral cochlear implant in those cases, we did not face any major issues with their balance. So they got a trauma to the inner ear twice, and in spite of this, they still were happy with the cochlear implant bilaterally. And then we publish this paper, which is simultaneous bilateral cochlear implant in adult. And we looked to those 27 patients. Their age varies between 19 and 70 years old, and we look to their main complaint in the first visit. And you could see here, the balance was not a major issue. What was the major issues is the tinnitus, and with the cochlear implant, hopefully we'll be able to handle it. And then loud noise, and they need a few adjustment of their sound, some pain and so on. But all of them are not a major issue to stop us from doing bilateral simultaneous cochlear implants. And this first concern, balance, was not really a major issue when we did a cochlear implant. So what about the hearing? Can we wait for a month and they get fitted with cochlear implant on both sides? In reality, we look to our practice of different cochlear duct length in Saudi Arabia. And we found in Saudi Arabia, we have a different cochlear duct length compared to the Europe's, a smaller cochlea, and somehow bigger than other end of the world in Asia side. So we are almost in the middle. So by this, we will be able to see how big is the cochlea, and according to the anatomy of each cochlea, we fit them with the best electrode, and we program it according to this anatomy. But the issue with this one is post-operatively, and how can we manage this by doing CT scan for every patient? And this was not an easy issue for the anatomy-based fitting. I'll let you know what we have done. But look at here, the frequency mismatch with the cochlea, okay? And you could see here with the longer electrode, the standard electrode, we have less mismatch. So the longer electrode for the cochlea, the better mismatch between the default setting and the anatomy-based fitting. So this is another thing encouraging everybody to look to the anatomy of the cochlea and tailor this fitting according to the frequency for this cochlea. And then the other issue was the CT scan is a major issue to do a CT scan post-operatively to localize exactly where is the frequency for these positions. And we were lucky to find it easy by doing just plain X-ray. And by plain X-ray post-operatively, which we do it almost routinely for all of our patients for different reasons, we were able to use this X-ray to localize the anatomy and the frequency for each cochlea. And this paper, it's already been published, and I hope everybody would look at it and use it and make their life easy. And you could see here, it's being, this software of Otology is being integrated in a way that it uses the plain X-ray to localize exactly the frequency after implantations, and accordingly, this will be moved to the maestro, and accordingly, the patient will be fitted on the anatomy. That would make it faster and easier for the patient to understand and to hear easy than what we used to wait for a long time before. So with this, we are able to handle the balance. We are able to get a better fitting and better stable map faster than usual for our patient. But what about general anesthesia? In those patients with bilateral simultaneous cochlear implant, definitely will take longer time than unilateral. It's not double the time, it's actually shorter, but still it's longer. So how can we cut this general anesthesia time? So we thought about doing cochlear implant under conscious sedations in our patient and do them as a day surgery and same day fitting. So we did it even for bilateral cases, and we did them under conscious sedation, and we fitted them intraoperatively, and we send them from recovery room to their home. So this is another thing that make cochlear implant much easier and much attractive for a lot of elderly patients, because their main concern was not the cochlear implant. Their main concern was the anesthesia. So by conscious sedations, we were able to remove this hassle and difficulties for a patient to accept cochlear implant. And then this is a paper which just been published, okay, and it shows that the early activation, it would give you a low impedance in a cochlear implants. And we know that the impedance is the biomarker we have for hearing preservation. So by doing early activation in our patient, actually it's another added value that we preserve the hearing. And you could see here in this graph that the impedance is lower in early activation. And believe it or not, this is a result for 2 years. For 2 years, it's continued to show that the impedance is lower in early activations, and this would go more with the hearing preservations in our patients. So by this, we know by doing bilateral cochlear implants, we still have a good chance to have hearing preservations if we do early activations. So by this, we were able to control the general anesthesia issues and also for the hearing preservation. And by this, I think we're almost all ready to go with the bilateral simultaneous cochlear implants in adult with no major concern and worry. This is one thing I would like to show you, that the Guinness World Records for one hand of heavyweight lifting is 300 kilos. This could actually go down if we use 2 hands anyhow. It goes down to 230. But if we both hand together, we could lift 530. This is the records. So you could see it's not actually the double, but if you do not put them all together, synchronizing each other, we will not be able to reach this weight with one hand. So basically, 2 hands definitely will give you better, 2 hearing with 2 ears definitely will give you better hearing. And at the end, I would like also to welcome you all to the 3rd Arab Cochlear Implants Conference in October. Thank you.
Thank you, Rahman. That was very good. I don't know if weightlifting is the same as hearing, but the comparison is nice. So let's go to the question of our chairman, of Professor Hagr, concerning sequential versus simultaneous. I understand that you also prefer simultaneous rather than sequential. Is this right?
Well, actually, we ask our patient what they prefer. Okay, in reality, they prefer to have one surgery, as this is applied to everywhere. For the knee replacement, for any kind of surgeries, they would like to have it once. And I think by doing bilateral simultaneous, we give this benefit in one surgery. And we have seen it clearly in pediatric, how much parents are excited to do it once and how easy for the audiologist and to rehabilitation people to do it simultaneous. So I just think the same thing is for adult bilateral simultaneous cochlear implants would give you the same interest from the patient side. So I'm answering from the patient side, not from the surgical, because as a surgeon, all of us would love to do bilateral simultaneous.
No. Okay, Ranjit, you're the audiologist here. And remember, our audience was mainly audiologists. Simultaneous, sequential?
I would go with simultaneous, but one important reason is it gives you the not just the ease of programming, but also in terms of development of the communication skills and development of the auditory skills is much better when you do simultaneous compared to sequential. Now, when you do sequential, there's always a comparison when you do a programming on the second implant side, and it's always compared with the first implant side, the quality of the sound. So, matching the expectations becomes a little more difficult in all cases, though it's going to take some time with consistent training. The brain will acclimatize over a period of time. But for the ease, I think it's better to go with simultaneous.
Okay, simultaneous 2-0. Joachim, 3-0?
No.
Good.
I think it's a little bit more complex, and we should not discuss it just from the scratch or from the desk. Reality is different and much more complex. We have to differentiate whether it's adults or children. Reality is that the majority of our patient has asymmetric hearing. So for the adult population, we are implanting patients with some substantial residual hearing, and usually they have asymmetric hearing. And these patients go for a while by model, and then the CI takes over, and then we end up with a sequential surgery because of the medical situation.
Okay,
Also,
this is because of indications, right? This is not...
because of indications.
Okay.
We hardly see no deaf patients, completely deaf, waiting for an implant. Those has been operated 20 years ago, and nowadays the knowledge is in a way that if the patient understands more than 30-40% monosyllabic words, he asks for a cochlear implant. That means when he cannot use the phone on a regular basis with his family members, then he asks for an implant. So the situation has changed. In children, we are also facing a situation that they have residual hearing, and they, luckily enough, need not to be completely deaf. And usually also they are facing asymmetric conditions with some benefits from the hearing aid. In children, we are going to lower ages at 1 year, and we love to do them even below 1 year. And then your setting comes into the game. The anesthesiologist plays a role. A 1-year-old child has 500 milliliter of blood. The anesthesiologist should be feeling comfortable in putting this child to sleep. The audiologist wants to do evoke potentials prior to the surgery to confirm the decision. And then you are running into a time problem. And a short anesthesia, or at least the opinion of our anesthesiologist, is that 2 shorter anesthesias are much easier and better for the child than 2 longer ones. And therefore, we make the decision individual. About 20% of our patients had been implanted simultaneously, and 80% are implanted as a staged procedure. And the real world is not black and white.
I think, as a general conclusion, it's obvious that from a purely theoretic standpoint, bilateral cochlear implants are better than unilateral cochlear implants, that's for sure. However, unfortunately, we don't live in utopia, and real life is more than just pure theory. Real life makes things a bit more complex. Number one, as was mentioned by Professor Müller, life is not black and white. We cannot say we always do this or we always do that, because the situations are completely different. So you have to individualize, which is the crucial key for success in medicine.
And that's all for today's journey in Beyond Sound. Our heartfelt thanks to Professor Abdulrahman Hagr for his insightful talk, and big thank you goes to our panelists, Professor Joachim Müller, Professor Ranjit Rajeswaran, and to Professor Javier Gavilan for guiding today's thoughtful discussion on bilateral cochlear implantation. This series is brought to you by the Hearing Group, a worldwide network united by one goal: to restore hearing, connection, and quality of life for people everywhere. If today's conversation inspired you to keep learning, we invite you to visit our educational platform, boost.hearing.com. There, you can access masterclasses, symposia recordings, expert lessons, and comprehensive courses led by the leading experts in the field. We hope you enjoyed this episode, and we'd love if you hit the subscribe button, whether you're listening on Spotify or watching on YouTube. If you'd like to be a part of the Hearing Group community, come join us on social media. You can find us on LinkedIn, Instagram, YouTube, and Facebook. Just look for @HearingGroup. So slowly it is time to say goodbye, and thank you for being part of this conversation, for going beyond sound together. Until next time.